Well, hello, and welcome to my video on drugs that are affecting blood coagulation. So when the body gets injured, we know that this miraculous body undergoes this immediate attempt to try and fix that problem, to stop the bleeding, to plug up the system by a variety of ways. We know that it's a complex process of vasoconstriction, those blood vessels getting smaller, platelet clumping or aggregating, right? Rushing to that site and forming that plug. And we know that there's also a cascade of clotting factors, the intrinsic and the extrinsic pathways to form those clots. If you look at on page 827 in your text, figure 48.1, it goes through those processes of how the body coagulates. Now, there are certain times when the body will be more at risk of coagulating or making clots, similar to how your patient Rachel Hedebrink received or got a pulmonary embolism in your virtual simulation after surgery and being um, bedridden for a prolonged period of time. So we know that there are drugs that affect clot formation, include antiplatelet drugs like aspirin, which alter the platelet aggregation and the formation of that platelet plug. Anticoagulants, which interfere with the clotting cascade and thrombin formation, such as heparin and warfarin. And then lastly, we have thrombolytic agents, which break down a thrombus, which is already formed, or a blood clot, by stimulating that plasmin system. And a medication such as this would be urokinase. Now, for your exam, you do not need to learn the last classification of medications. You just need to learn the first two. So how do we measure if a patient has a prolonged bleeding time? When we're giving some of these anticoagulant medications, we're going to be monitoring their bleeding time because it's a fine balance, right? We want them to not form a clot, but we don't want them to bleed either. So we measure bleeding time in PT, PTT, and INR. We're going to go through those. So the first medication that we are learning about is one that we already learned about, and that is aspirin, and that is your antiplatelet medication. We already learned about this medication, the salicylates or aspirin, when we learned about medications for pain or decreasing fever. But this antiplatelet drug, aspirin, blocks the receptor sites on the platelet membranes, preventing that platelet interaction. So antiplatelet medications, we need to make sure that patients are being monitored for excessive bleeding. This is a nursing priority, pens up. So we want to ask them if they brush their teeth, if they're bleeding. They should not be receiving intramuscular injections because that would increase their chance of bleeding. We want to prevent that if possible. And remember, aspirin is used to decrease the risk of strokes with history of emboli or to reduce death and myocardial infarction in patients with angina. And it's also used for a myocardial infarction or heart attack prophylaxis. And we also know that it's used in anti-inflammatory, analgesic, and antipyretics. We're studying at this module for its antiplatelet functions. So blood clots. We know that the highway system of the body, the blood vessels, we can think about like a garden hose, and that highway system can get plugged up, with blood clots. We call this a thrombus or an embolus. And the treatment for that would be an anticoagulant to prevent these blood clots or embolus or thrombus. Now, two medications that we're going to review that we're looking at that affect coagulation are heparin and warfarin. We know that heparin blocks the formation of thrombin from prothrombin. We know that it's used to prevent venous thrombosis or pulmonary embolism. We know that heparin must be injected. So we don't use that in outpatient very much, right? If a patient goes home on anticoagulant therapy, most likely they're going to go home on warfarin because that is administered by mouth or PO. Warfarin or Coumadin, we know decreases vitamin K. So that depletes the clotting factors. It prolongs that clotting. It is used also for patients who are susceptible to potentially dangerous clot formations. Now, heparin, we know we want to monitor that bleeding time. So you have a patient who's on heparin, they are on that to prevent a thrombus, pulmonary embolism. So we need to make sure that they're not decreasing that chance for blood clot too much. They would be too high risk of bleeding. And one way that we monitor that is by the PTT, that partial thromboplastin time, bleeding time, PTT. And if you remember, if I point out here, this PTT, if you put those two small t's together, what letter does that look like? An H, right, hands up. It looks like an H. So remember PTT, you look at when you are having a patient that is on heparin. If the PTT is too high, we know that the patient is at risk for bleeding. If the PTT is too low, we know that the patient is at risk for forming a blood clot. So where should that PTT be? That PTT should be about 1.5 to 2 times the normal bleeding time when a patient is on heparin. We want that bleeding time prolonged 1.5 to 2 times what they normally would be bleeding. Hopefully that makes sense. Now, the next medication is warfarin. And warfarin, we know that if a patient is on that, what level are we going to be monitoring in their labs? The PT, the prothrombin level. So that bleeding time. Again, sorry, I put PTT there. It should be PT. If PT is too high, we know that they are at risk for bleeding. If the PT is too low, we know that they're at risk for a blood clot. There we go. Sorry about that. PT. Oh, back up 1 second. Go back to that warfarin level. We know that warfarin should be 1.3 to 1.5 times the normal level when someone is on warfarin, right? So we want that we want the patient to take longer to clot, right? That's the whole point of anticoagulants. We want that bleeding time to be prolonged. We don't want them to rush and make a clot. So we want it a little bit prolonged, just a little bit more than normal. 1 is the normal, so 1.3 to 1.5. We want that bleeding time just increased a little bit. And then next, because all labs are different, right? Whenever you are monitoring any labs, you're going to get what's called a reference range. All labs are different. All reference ranges are different. So we want to make sure that we are judging these patients in a standardized way. And the INR is the International Normalized Ratio. So you always want to be looking at this when you are looking at prothrombin levels or warfarin levels. You want to look at that INR even more than the PT because it's standardized. So the INR, and this is a huge pens up, you're going to need to know this forevermore in med-surg and as a nurse and NCLEX. The INR should be 2 to 3.5 times what it normally is, okay? So the INR, you really want to look at that number. It should be 2 to 3.5. And what are you going to do if it's too high? Well, if it's too high, you know that the dose of warfarin is too much. So we're going to either hold that dose, notify the provider, watch for signs of bleeding, really important. If that INR is too low, then we know that the dose for the warfarin is too low and we need to increase that. So we know also that when you have a patient who is receiving heparin, if they overdose on it, they're bleeding. You need to stop this. You need to reverse this heparin. What's your antidote? Pens up, protamine sulfate. You want to make sure that if you have ever a patient that has heparin, you have that protamine sulfate available in case you need it. Hopefully you never will, but you always want to be prepared. Next, if you have a patient who is on warfarin and they have an overdose, they're bleeding, they would need to have vitamin K available to administer in case they are needing that. So I kind of summarized this for you. So if you have your patient on heparin or warfarin, you want to kind of memorize these numbers. So if you have a patient on heparin, you're monitoring that PTT. Again, remember the two small t's together look like an H. Should make this really so it's easier to see, right? That looks more like an H. PTT should be 1.5 to 2.5 times, and your antidote, protamine sulfate. Excuse me. If you have a patient on warfarin and their lab values, you're looking at PT 1.3 to 1.5, but more importantly, you're looking at that INR, should be 2 to 3.5, and your antidote for that would be vitamin K. For all these patients, you are closely monitoring, making sure they're not showing signs of clot formation and they're not showing signs of bleeding, that happy medium. You're avoiding other over-the-counter drugs, such as aspirin, which could increase the chances of bleeding. All very important. You are also avoiding intramuscular injections. You're not going to purposely give them an injury when we're prolonging their bleeding time. All right, so here's a case study. So you have a patient who is high risk for a pulmonary embolism, and they're ordered to have heparin. So first question, which lab value is a priority to monitor? Remember, heparin, that H, put that H, you separate that H and it looks like two small t's, so that is excellent, great job. PTT, you're monitoring their PTT. Next question, what level do you want that lab value to be at? Excellent, 1.5 to 2 times the baseline. Great. And what teaching would you provide the patient? Right, you're watching out for bleeding. Or when you're brushing your gums, are you noticing any blood? Do you have bruises? Be careful about injury. You don't want to fall down because you can have internal bleeding. It's really, really important. Safety is huge with these patients who are on anticoagulants. And lastly, your second case study, you have a patient who is high risk for a blood clot and is ordered to receive warfarin. First question, what is the priority lab value to monitor? Excellent, INR. You can look at the PT, but that INR is standardized. And what level should that be at? Excellent, 2 to 3.5. What might you expect to see in the patient if that number was too high? Let's say it was 3.6, 3.7. What would you notice? Right, maybe nothing. It might just be a little bit higher. So you need to assess the patient, find out, are they bleeding? If it's very high, they may have excessive bruising, bleeding. You want to notify the provider, absolutely. And if they're overdosed on that, their number is through the roof, then you're going to administer the antidote for that drug. Excellent. Great job. Have a great rest of your day. Thanks for listening. Bye-bye.